The shift to a value-based care system requires a paradigm shift by everyone. That means that both the patient, the provider, the system as a whole has to buy into that model.
Welcome to Meeting the Minds with Wobot Health. I'm your host, Chris Hemphill. Value-based care shakes up how we administer and deliver mental health care. However, most of the info out there just covers the administration part. We want to focus on the big changes and expectations for physicians, clinicians, the people that are actually doing the work. It's important for everyone, not just clinicians, to understand these changes because it might help inform the policies that you ultimately choose to put into practice. To drive this understanding, we met with Dr. Maria Koshy, who is chair of Chiefs of Psychiatry at a well-known organization steeped in value-based care, Kaiser Permanente. In Maria's role, she leads over 2,000 psychiatrists and allied health professionals while continuing to practice herself. So her eyes are never off of the clinical experience. She's in it every day. In our conversation, we talked about the culture shock that she experienced moving into U.S. healthcare and eventually into value-based care. We spoke about the impact on clinical practices, the differences between value-based care and fee-for-service environments, and how to navigate other clinicians through that same culture shock. I want to thank the Future of Mental Health, which is a biannual summit for mental health leaders, for facilitating this conversation. So let's get on into it. What can we learn about value-based care from frontline clinicians?
We've talked about your background in psychiatry and what you're leading at Kaiser Permanente, but I'm wondering about, as much as you feel comfortable about sharing, the journey that's led you to this place. Why the specific focus on this role and within this care model?
Well, I spent quite a few years in Toronto, in Canada, before moving to the U.S. And one of the big differences I noted right off the bat when I moved to the U.S. Was the difference in healthcare. So Canada, as you all know, is a single-payer system. And as a patient in that system, it was very smooth in terms of entry into the system. Everyone had access to a health card. When you go to the emergency department, you show up at any clinic, everyone takes that health card. And you can access care everywhere. Versus when I came here in the U.S., it was very much the first thing you get asked when you go into an emergency department is not what's wrong. It's okay, well, what's your health insurance? And it was such a foreign experience for me. I definitely noticed that more when I was in medical school and in residency. So when I was getting towards the end of my training in psychiatry, I looked around and a lot of my peers were going into private practice, going into settings such as that. And I really wanted to be in a clinical setting where I had diversity in my practice, be it socioeconomic diversity, cultural, ethnic, and clinical diversity as well. So I knew I needed to be in a large system. Mm-hmm. And then I, was thinking about large systems, and what I liked about Kaiser Permanente is that it really does, as a system, we take care of everyone. And we're responsible for everyone who prescribes to the helpline. So it's, as a frontline psychiatrist in Kaiser Permanente, I don't need to think about what insurance my patients have. I just practice clinical medicine. And that in itself is extremely liberating on a day-to-day basis to be able to practice in that manner. I'm also, on a broad scale, aware of some financial stewardship that needs to happen, particularly when it comes to medications and so on. But that's a focus of the practice rather than focus on the individual patient and what they can or cannot have. So that's what drew me to KP, the freedom in practice. And what's kept me at KP is, I'm sure we'll go into it, is the added dimension of clinician or physician leadership and the joy that brings.
Excellent. And I love your story because I really think that anybody listening, what they hear is you came from a different health system, and you said, hey, we could actually be doing a whole lot better than this. At the very least, you found a way to work in a place that's enacted the type of system where you can thrive as a clinician.
Absolutely, yes. And I have really enjoyed having that broad scope in my clinical practice in terms of who comes into my office.
So can you tell us, can you share a bit about the role of Chair of Chiefs of Psychiatry and what that puts under your purview?
Absolutely. So I've been chair of Chiefs of Psychiatry and Behavioral Health for the last 3 years. So in my role, I'm part of the Permanente Medical Group. We're the care delivery arm of Kaiser Permanente. And we have about 2,000 clinicians, so MFTs, LCSW, psychologists, and about 400 psychiatrists in Northern California that work at various medical centers in Kaiser Permanente. And in my role, I lead my peer group of physician and clinician leaders who manage departments in all of those service areas. In my operational role, I get the really fun part of my job is really leading the peer group in designing systems of care that provide a consistent experience to all our members across Northern California. That is definitely the fun part of my role. And then the part of my role that has been a growing experience is in really getting to dive deeper into the roadblocks that come with trying to deliver care at scale. Trying to take evidence-based models that are often developed in a controlled environment and translating them into models that can be implemented at scale for 4.5 million people.
I was very curious about the number of lives that you're that are under your purview. One thing I'm curious about is the opportunity to rise to the occasion for this role. How did you come into the opportunity to expand that focus into being able to develop these plans and journeys and translational elements for such a broad population?
Well, another great thing of working for TPMG, the Permanente Medical Group, is that, as my needs and capacity and bandwidth evolved, there were roles that were available to help me meet where I was at. So when I started, I was part-time. Only had one kid at the time. Thought that was, a lot of work back then. Had one kid as part-time, and I was part-time in full-time in clinical practice. I did the intensive outpatient program in outpatient psychiatry. Had another kid, expanded the brood. And expanded my bandwidth. Somehow that magically grows as well. And got to the stage where I wanted to be a little more involved in developing systems in addition to delivering clinical care. So I started taking on smaller leadership roles in my local department and then became chief of my local department, did that for a few years. And then the chair role became available and I applied and got the role.
Well, congratulations on that, and always happy to hear about there's operating at the top of the license with individual patients, but if the opportunity comes to expand that focus and take some of these learnings and help grow that at a leadership level, that's always exciting to hear about too.
It's a valuable perspective. One of the tenets of working in this organization is everyone who's in leadership continues to have a pretty significant component of practice as well. So I'm a leader in the organization, but I spend 40% of my time at any given week in clinical care, direct clinical care as well. And it's a bit of a juggling act at times, but it is so valuable to have that perspective as well, because there's a certain level of groundedness that comes from that aspect of my job that lets me translate a little better than if I were completely removed.
So we're going to be talking about some higher order concepts, but with that grounding within hands-on frontline work. So I know that there's a lot of information out there on value-based care and fee-for-service and all that. I could refer you to another episode that we did with Antoine Williams on kind of the building blocks around value-based care. In your world, like you explained it beautifully about coming here and seeing the biggest flaws in our healthcare system. So what are the main benefits of looking at this value-based care perspective?
Well, from a provider perspective, as I said earlier, it really takes that tension that often exists in the fee-for-service world in the individual providers' hands of reimbursement and looking for reimbursement for individual patients. It takes that tension out of that individual provider's hands and brings it up to my level and higher. And so that is, I think, from a provider's perspective, really helpful because the organization as a whole is compensation in a way is also very closely tied to outcomes. That's also liberating from a provider perspective because the goal isn't necessarily to generate income with frequency of care. The goal really becomes about creating throughput in the system so that we can get more people back to their lives sooner. And so recovery and response to treatment really becomes a goal at the individual provider level. And it's a shared, aligned goal at the systems level as well, because we have clinician leaders like myself who are in the room for the conversations about designing the system. From a member perspective, the hope is to instill that confidence that the system's focus is on improving outcomes and improving care. And I think we'll talk a little bit later about the roadblocks, but there is sometimes a dissonance in that perspective from the members' perspective of what is high quality mental health care. Because I fear that a lot of the language around high quality mental health care is related to utilization alone, and it may not be.
That's a great point, especially like it's kind of endemic in it's intrinsic to the word that we're describing it, right? Is if we say healthcare, that is that's the word care implies that there's treatment involved, and a lot of times like a high quality, let's call it a health experience, involves being able to care for issues ahead of time or take preventive measures so that the care element doesn't even have to come into play.
That's right. And that's the way it should be, where our focus as an organization is on what can we do at scale so that our members don't end up needing to go to the hospital or their emergency room. And what that means at an organizational level is really focusing resources upstream in primary care, in specialty mental health, in the outpatient space, so that people don't get to the acuity level that they need to access resources in a more acute space.
You just mentioned the word upstream in that description. And for those that aren't familiar with the concept, downstream refers to like delivering care in the moment, whereas upstream looks at all the things that you might address that might impact care outside of what's happening in that room. For example, a term that you hear a lot is social determinants of health, looking at the environment that someone's in, the availability of food, shelter, and basic services, like addressing these upstream issues. Perhaps an example might be, this is one that I heard from someone focused on home health, was putting an air conditioner in someone's house, and like a $80 space heater prevent much greater cost on down the road when that person might present in the ER. Am I getting that right with that term?
Yes. So upstream can refer to all the elements that are outside of the room where the care is being provided. We do have, we're developing systems to really identify where those gaps are for our members, and then connect them to community resources where they can access assistance for those elements as well. I was also referring upstream to the entire journey, because often by the time someone gets to where I'm sitting in psychiatry, they've usually been suffering and struggling for a while. Partly because there's, not everyone seeks care early enough, and partly because it takes time for, symptoms to build up to the point that they're in specialty psychiatry. So in an integrated care system, in order to meet that imperative of helping our members and patients thrive and stay healthy, it really does involve investing resources further upstream in the patient's journey. So, if you show up in a primary care office and you're not, clinically depressed, but you're stressed, how easy and accessible is it for you to go from that setting to accessing resources that you need? And so we've been putting elements in place that make that journey from that setting where it's not acute to the level that you need to see a psychiatrist per se, but you're struggling, and perhaps intervention at that point in your journey may prevent you from needing more services down the road. So we've been putting, systems in place so that that care is accessible, and once you access the care, that you get high frequency care up front in order to get you to response and remission. So, we put in a population-based collaborative care program. 22,000 people have gone through the program. We have remission response rate in the 60%. We can get you better and back to your life as usual in 6 weeks or less. And that being able to do that and being able to see those results is really fulfilling as a clinician, physician leader, because it meets that imperative that I carry, that we need to keep people healthy.
So yeah, and that really hammers in on some of the, like I love the detailed description on the care journey, and where there are elements to impact, like you were bringing up, if somebody's bringing up stress, like what if we start addressing that issue much earlier, then it becomes something much deeper. So, I mean, we've been talking about the benefits, but honestly, when I talk to a lot of people, there is a lot of fear around shifts towards value-based care, and that's often extremely valid. Like I love the description that you're sharing here, but I wonder about the types of pressures that clinicians face in these environments, and what are some unique challenges that people should be wary of and hopefully avoid?
Well, the shift to a value-based care system requires a paradigm shift by everyone. That means that both the patient, the provider, the system as a whole has to buy into that model. If you're looking, so value-based care implies that the financial reimbursement is really tied to improvement in outcomes and response to the treatment. And when you're responsible for an entirety of a population, it means that the amount of care that's needed to get to response in someone who's mildly ill is going to look different than the amount of treatment that's needed to get someone who's very ill to response and remission. And there needs to be, acceptance, I think, and engagement about that. Because as a frontline clinician, sometimes I do have to deal with expectations in the community about what care should look like, and it's often tied to frequency. It's, shouldn't I be seeing you once a month or once a week, and so on. There are situations where I do see people that often, but I can't do that for everyone, because then the people who are very ill will not have access to my care, because there's a limited number of providers in the system. So what that translates to is there is a little bit of constriction and perhaps patient autonomy. And maybe that's where the struggle is, that you're alluding to that people are struggling with.
Yeah, yeah. Like I know that there are capitated models and models where people are, like, I guess in Kaiser Permanente's case, it's led by that primary care setting, right? Like what I believe they call it a gatekeeper model, right? Where you go in, but you can't see a specialist until there's that initial primary care setting.
Well, actually, no, we're self-referral.
Oh, my bad.
Yeah, no, you can, if you're a Kaiser member, you just pick up the phone and call the psychiatry department yourself. You can. You can also get referred through a primary care doctor, but you can self-refer at any point. It does not require referral by anyone else in the system.
We were talking about value-based care from, like, we're talking about the general area of it and economics and all that. I'm curious about the unique approach or the unique benefits and challenges in with value-based care in a mental health perspective.
Well, we were speaking earlier about expectations in the community about what mental health is. One of the specific challenges is there, at least that I've seen, I haven't seen a clear consensus on what the indicators of quality are in mental health. So different groups have different, indicators that they look for. If there was consensus around what the quality indicators are for mental health, then as a system and as individual providers, we can set up the infrastructure to measure those quality outcomes. So I think that's definitely a big barrier. What I've seen is, so for instance, if you have cancer, an indicator of a high quality system is mortality rates, perhaps, right? In mental health, there doesn't seem to be a clear strategy around what those indicators of a high quality system are. And in that vacuum, a lot of the language is around access to frequency of care.
So it is a gigantic challenge, right, to understand how these quality measures might differ around different sites of care and coordinate between those sites to have some sort of unified language to say this is the amount of concern that we might have for this group of people.
And even the measures. Is there consensus around the measures used to measure depression over time, anxiety over time? Are those, the expectation to report out on those measures, is that being uniformly applied to all systems?
So now we know it in many different health systems. Like they're like from site to site, there's major differences, even in the way that data might be collected and labeled. I wonder, like, given this disparity of measures and how they're interpreted, are there systems that you've looked at putting in, like approaches that you've looked at putting into place to help alleviate these issues or coalesce leaders around?
Yes, so internally within KP, we have a system to measure progress in treatment in care, and we partner with Lucette to allow members to, patient-reported outcomes, basically. So patients get questionnaires that are delivered to them electronically before the appointment. If they're not able to fill it out, then they fill it out in the waiting room. So we've built out the infrastructure to collect those outcomes data. It still requires, efforts to engage patients and members in the importance of providing that information, and it requires that interface between provider and patient to look at that together. Because as a member, if I'm sitting and filling out questionnaires and yet nothing's being communicated back to me, about how I'm doing or how that's factoring into my treatment, then I become less invested over time in putting in the effort. So there's the systems piece that has to be set up, and the investment has to be made to set it up. And then there's the next piece is continuing to engage both providers and patients in the value of collecting the data itself.
Oh, so I was just I could snap and clap here because it was just I like the frame up of if we're going to be asking patients for more data, more collection, we have to have some sort of return, something to answer the question, what's in it for me?
Exactly.
You don't want that, like if it goes into a black hole, then it just feels like the effort was completely wasted. And why am I filling out this survey, these same questions over and over again?
Absolutely. There has to be a patient interface to be able to see and track your own progress over time. And once you have those pieces in place, then you're able to really see how your system as a whole is doing and the population as a whole is doing. Now, one of the challenges, and this is where what I said earlier comes into play, is if we're the only ones doing it and there isn't that expectation out in the community for that level of reporting, then that becomes challenging as well. And this is where I think, HEDIS measures, NCQA, there's all these entities out there that do set quality outcomes expectations for systems as a whole. And I think there's work to be done there.
Definitely, and you bring up a really powerful point because like I've asked all questions kind of self-contained within Kaiser, but there's a whole network of data only reflects. There's data that lives in all these different silos, and even though from a technical perspective, it would be it wouldn't be it would be laborious to connect these sources, but it is possible. But the hurdles that exist are societal, based on competition and our our culture of competition.
And, we as a large system can make those investments in infrastructure. I can see why, as an individual provider in the community, that's going to be challenging to be able to make that investment in infrastructure without any additional support or a level of buy-in into why that would be important.
Now, one question that I have is you came into this health system and you saw a lot of the flaws inherent in the system and found a system that you identify with. I'm curious about other clinicians that, they're coming in and acclimating to this way of doing business. Are there challenges that you see from people who come from other environments, and how do you acclimate folks to this value-based care paradigm?
I was just doing an onboarding session with some of our new clinicians this week. And what I really talked about was that paradigm shift of functioning as an individual in a large community versus functioning as an individual within a large system that has an entire ecosystem of care. So when you're an individual in the community, you have to be everything for your patient. When you're functioning as an individual provider in a large system, you have to be strategic about delegating where you can, because those resources are available. So, for instance, our ecosystem of care extends from self-care apps and wellness coaching and those resources all the way across to the other end of the spectrum, where we have intensive outpatient programs and residential care and inpatient psych and providers embedded in the emergency department, and where as a system we're built to have those handoffs happen in an integrated manner, but it requires the provider to shift paradigms to not having to be the sole person holding all of the patient's care in their hand, but to also delegate where possible, so that it becomes a sustainable practice over time. And that's the shift that I went through when I came here, and one of the challenges is it takes a while to get to know the system, because it is a large system and it's complex and has so many layers to it. So I was telling folks during the onboarding to take your time and learn the system and lean on peers and managers in the system to identify all of the resources that are available.
Not only like it's not, hey, here's a tome that says all the rules and regulations and how these departments connect, but it's also about patience and inspiring teams to help each other in the moment and acclimating to this new way.
Absolutely. We've all discovered during the pandemic just the vital importance of connecting to others on your team and how that makes the job sustainable. Because we lost a little bit of that when we all went virtual for a period of time. So that connection to the team and others around you, particularly in a system as large as ours, is what keeps most people coming back to work.
So when you look out and see the excitement around the value-based care initiatives and movements, again, the panel that you're speaking on ask, is value-based care the key? What are some of the kind of hidden things that you wish people knew that were like more known in the discourse? What's hidden that people should know about this value-based care movement?
I definitely think that as a society, we have to buy into the validity of the model for it to work effectively. It requires engagement at the patient level, provider level, and at a systems level in order for the model to succeed. If there's consistency in how we measure outcomes across the system, then we can tie that to reimbursement and the financial piece of it. And then there's incentive for everyone to build the infrastructure needed to measure those outcomes over time and be able to report out on it. But it does require that consistency in expectations.
So the big conversations to be had at organizations that might be newer to this are, hey, one thing we should make sure that we're doing is coming together on our metrics that we use to gauge success or failure. And beyond that, it's one thing to have metrics, but it's another thing to have the infrastructure that actually measures them.
Absolutely, yes. And as I said earlier, it's not just the infrastructure, but then the resources to build the engagement required after the infrastructure is built is really key.
Understandable. And like we're thinking from this systems level, I want to get into how you measure success at the systems level, but I'm very curious, perhaps at the difference in patient response that you've heard in fee-for-service versus value-based care environments.
I would say that I can speak to patient response just in terms of outcomes in our system, because we can focus on really, getting patients healthy, getting them well, and we're able to put those resources in. We're able to see those outcomes in a very transparent way. And we've published, in peer-reviewed journals as well, and really published results for some of our more severe, more ill patients. So people with schizophrenia and schizoaffective disorder and bipolar disorder. Those are the populations that we do talk about at conferences like this. But those are often our, hardest to engage populations and population of patients with lower life expectancy than our mildly to moderately ill population. So we are able to see those outcomes because as a system, there's engagement in the importance of keeping people well and keeping people healthy. In the fee-for-service world, I think what I've heard is once people get into the system, and I've heard there's definitely challenges in finding providers in the fee-for-service system. Once people get into the system, the outcome of that is dependent on the individual provider, and some people do well, and some people don't. I can say that, from our experience with also working with providers in the community, sometimes we, have providers who reach out to us and say, the acuity level is too high for us to manage. and we think this person might be better served, internally in the system. So when you have siloed practice, it can be challenging to really meet the needs of people who are very mentally ill and who are not able to function well. So those are, that's the trade-off if you're in a small independent practice. The capacity to manage that can be limited.
Thank you for sharing. And another theme that I've seen at the conference is that there's a significant amount of focus on people in mild to well categories. But just across the broader landscape, they're hoping for more resources and assistance for those more severe categories that you were discussing.
Yes, and there is value in also putting like resources up front. But I think, as a system within KP, as I said earlier, I'm privileged to be able to take care of a whole range of acuity, and privileged to be able to put resources in to take care of the whole population.
So the being able to take care of the whole population, another major theme that I'm seeing pop up more, and rightfully so, is around health equity. I think a lot of our questions, a lot of the conversation points at a better picture for health equity under this model, but just curious about your thoughts on how health equity is enacting and manifesting in these types of environments.
It's when you start measuring outcomes, then you start to see the inequity in outcomes across demographics, across racial groups and ethnicities. So when you see those differences, then you get to shape a system that is targeted towards this population of patients. So within KP, we know that if you're African American, you're more likely to have hypertension, issues with managing hypertension and so on. So we, can focus more outreach on that population. With depression as well, we find that certain demographics and racial or ethnic minorities are less likely to engage in care in a large system such as ours. So and there's a lot of factors and variables that go into why that is. But it creates opportunities for us to look at how we can best tailor the system so that it is more, it's safe, it feels safe, and approachable for anyone.
Major point there too, just because in other models, it might not force these questions to come to surface with the intensity that it does when it's an outcomes-based approach.
Well, yes, and what we're finding is, often the population of providers that are in large systems don't necessarily match the demographics of the patients who are seeking care. And so we put a lot of effort into training programs. So we're graduating 250 different mental health trainees this year in various different types of licensures. And a big focus of our training programs has been to really encourage and bring in a lot of diversity so that mental health professionals that the demographics of the mental health professional teams, they reflect the patients that we're trying to reach.
It's extremely important just to see people coming from, communities, or at least like in my community, mental health it's difficult to discuss and highly stigmatized. To where I've been discouraged from seeking help because of the stigma that might be associated with it in many cases. So to start opening the door, and from the African American, from the Black perspective, if we see more people like us who are engaging those services and also delivering those services, it's been extremely helpful for me and people that are close to me.
Yeah, I come from a similar perspective. There's a lot of stigma around accessing mental health resources in the South Asian community as well. Quite a lot of stigma, and Often patients find me because I speak Hindi and, I look like them and can understand some of the cultural nuances that come with, their particular stressors. So I've seen that play out, and people travel distances to find providers who look like them or speak the same language as them, because there's a certain comfort level associated with that. So as an organization, that's an imperative that we have to train the workforce of tomorrow and really source, candidates for those programs that increase the diversity of our workforce.
Well, I appreciate you being candid on a lot of these approaches. Like really, what we were hoping for was just a frank conversation on what to expect, not just focused on the wins, but also what to expect in terms of pitfalls and how to help people, teams, clinicians, physicians adjust to this type of environment. One thing that we discussed ahead of time was that we can't solve all the world's problems in one podcast episode. I know, and
if it were that simple.
You were extremely disappointed that we couldn't solve it all in one episode. I'm sorry, but what if we flip the script and give you a magic power that it can't solve all the problems, but it can solve one problem?
Yes.
If there was a magic wand that let you solve one problem in how healthcare is delivered, what would that be?
This is going to sound not very exciting, but it's important. If it could solve a problem, it would be some consistency in how we measure outcomes in mental health across any care delivery system, whether it's fee-for-service, whether it's managed care. But I think having consistent expectations across care settings will go a long way towards, shifting the paradigm from where we're at today to a more value-based care system in the future.
Let's work on building this magic wand, because I think that we can't do it in wand form, but we can do it in terms of figuring out how to engage people, and like you were talking about earlier, driving that buy-in, driving that what's being reciprocated. How do I understand my progress over time if I'm being asked for these more consistent measurements?
Well, thank you so much for driving the conversation this way. It's just such a crucial part of the journey. Because the more conversations we have, if we don't name the problem, then it doesn't exist.
Exactly.
So the more conversations we have, the further we get towards that future ideal end state.
Well, super happy for you to join us and have the conversation as well. And I wonder, because there's a lot of people out here who are curious, they want to see this stuff over time and understand how the story evolves to impact and influence the story that they're creating within their own teams. Curious about where people can people find you online, or are there things that you think they should check out to just keep up with what's going on at KP?
Well, I'm on LinkedIn. I was telling you earlier, I'm not really on any other social media platform, just a little dated that way, but I'm on LinkedIn. And please, send me an invite to follow, and I'd be happy to add you, and we'll keep talking and continuing this conversation.
Honestly, I'm going to date myself too and just say, well, honestly, I'm on all the platforms, but LinkedIn is the best.
Oh, is that right?
LinkedIn is the best. You don't need any other TikTok or whatever. LinkedIn.
Sure.
You get the best conversations there. But yeah, again, big thank you there. And for the folks watching, thanks for taking the time, sitting down. I know we intentionally made the subject non-flashy, but we really appreciate what you shared today.
Thank you.
Thank you, and we'll see you next time.